Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Puyallup Tribal Health Authority for hosting today's session, Anti-Rheumatic Meds Overview for the Non-Rheumatologist with Dr. Katherine Upchurch. Dr. Upchurch retired from UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is professor of medicine at University of Massachusetts Medical School. Dr. Upchurch's abiding passions throughout her career has been the care of patients with all rheumatic diseases and medical education. And we're just so very lucky to have her as a MAVEN Project volunteer. So Dr. Upchurch, when you're ready, please begin.
Hello, everybody. Welcome to this talk. And also I want to give a special shout out to Kristen for her role in leading MAVEN Project towards being able to independently provide CME certified lectures such as this. And there is a process that's required, much more than just throwing together a few slides. There is a tremendous amount of information that I'm going to convey today. Probably at least 2 hours worth of a talk that's going to be squished into just an hour or so. So I'm going to talk fairly quickly, and some of the stuff I'm going to go over you may already know, but I think it's always worth reviewing, and I expect that a lot of it you have sort of peripheral knowledge of, but not direct knowledge of. As usual, we have disclosures that I'm going to go over quickly. Non-bias, and here's one about CME. So the objectives of this talk are to review different classes of anti-rheumatic drugs, to review indications for the use of these, to review common adverse effects of anti-rheumatic drugs, and in particular to review the role of primary caregiver in monitoring and prescribing anti-rheumatic drugs. So rheumatic disease is defined as a disease which affects joints and peripheral articular structures, tendons, ligaments, bones, and muscles. And it's no surprise that anti-rheumatic drugs are drugs that produce demonstrable, sustained or not, symptomatic benefit in patients with rheumatic disease. Recently, we've realized that it's helpful to classify anti-rheumatic drugs in a very particular way. The most accepted way right now is by dividing them into two broad groups: drugs which act rapidly and do not have the potential to prevent joint damage. Examples of these are non-steroidal anti-inflammatory drugs and also corticosteroids. And then the second group is disease-modifying anti-rheumatic drugs. And each drug in this group may reduce or prevent joint damage and preserve joint integrity and function. How the drugs work varies depending upon the disease and the patient response. And these drugs typically are slow-acting, which is another way that they are separated from the first class. So I wanted to present a case. 35-year-old man presents to your office after, quote, twisting his left knee, close quote, in a fall. His past history is pertinent for the fact that he was born with one kidney, but he's had normal renal function throughout his life. And on exam, his knee showed full range of motion with slight pain on motion and a small effusion. So the best approach is A, acetaminophen up to 3 grams per day, B, ibuprofen, C, celecoxib, and D, diclofenac. And then we'll go back to this question at the end of this section. So I'm going to talk briefly about conventional non-steroidal anti-inflammatory drugs, which are divided into two categories: conventional, which are non-selective, and those include many of the drugs that you're very familiar with, and then selective, which selects only for COX-2 inhibition. So the conventional drugs inhibit both COX-1 and COX-2, but the COX-2 inhibitors inhibit only COX-2. It turns out there's only one COX-2 inhibitor on the market now, celecoxib. You may remember the drug Vioxx, which was extraordinarily effective and extraordinarily toxic. And after much ado, it was removed from the market. Now, this is just a list of the common oral NSAIDs, and you can see there are many, many, many more of the COX-1 plus COX-2, and then you only see celecoxib. Many of these are prescription only, but in low doses, ibuprofen and naproxen can be, and I believe ketorolac can be acquired over the counter. But typically the difference between the over-the-counter and the prescription is simply a matter of strength. Now, the problem with NSAIDs is not that they don't work, but they really can cause sometimes devastating side effects. And so before you even think about prescribing NSAIDs, I want you to think about what we're going to be talking about going forward right now. So the adverse events are related to the mechanism of action. COX-2 inhibition, more so than COX-1 and COX-2 inhibition, is associated with esophagitis, gastritis, peptic ulcer disease, colitis, and elderly females are at greatest risk. So let me just rephrase that. COX-2 inhibition is much less likely to cause these things than COX-1 plus COX-2. So esophagitis, gastritis, ulcers, colitis, and also elderly females, much more likely to be affected by drugs that are not selective, such as ibuprofen, naproxen, and all of the others on the list. In contrast to GI adverse effects, renal effects are not selective, are not dependent upon whether a drug is COX-1 or COX-2, and these can be devastating, including acute kidney injury, acute interstitial nephritis, and can lead to ATN and even a need for dialysis if an individual is unlucky enough to get one of these complications and is not being monitored. The nice part about renal is that if you are careful about who you prescribe these drugs to, and avoiding them altogether is the best option. But if you need to use them and you select properly and you're careful, you might avoid renal complications and even GI complications altogether. Same is true with hematologic. These drugs cause decreased efficacy of thromboxane A2, which leads to increased bleeding due to platelet cyclooxygenase inhibition. So there are a lot of things that you need to think about. If somebody already has a bleeding disorder, I wouldn't use them. And we'll talk about this in a little bit, but if someone is actually on a drug that inhibits clotting, such as warfarin, I would not use conventional anti-inflammatory drugs. The other thing that is not thought about so frequently is that patients who have a history of asthma can have exacerbation of asthma flares if they are given an anti-inflammatory drug. And these can be severe, and these can be, in point of fact, life-threatening. So related to, but slightly different than that, is the fact that people who have a history of aspirin allergy can have anaphylaxis if they're given anti-inflammatory drugs. So on this one slide are many things to think about before you just flippantly encourage your patient to go down and pick up a bottle of Motrin and take 3 of them at a time, 3 or 4 times a day. So let's go back to case 1. He did appear to have an indication for anti-inflammatory drugs because he had an effusion, he had pain on motion, but he had 1 kidney. So therefore, any thing that impaired renal function would not be, potentially impaired renal function would not be advised. And all of the, both COX-2 selective and COX-1 plus COX-2 inhibitory drugs, all of them affect adversely, potentially renal function. So best to stay away from them all, and the appropriate answer would be acetaminophen. So the practical implications, avoid NSAIDs in patients who are volume depleted, who have chronic renal insufficiency, or the elderly who have, by definition, renal insufficiency compared with younger individuals. All of these patients are significantly at risk for renal disease. Avoid in patients with a history of peptic ulcer disease. Always tell patients to take these medications with food. And in the elderly, offer proton pump inhibitors in association with these, unless there's a contraindication. Use with caution in patients with thrombocytopenia, a history of bleeding disorders. And in patients on warfarin, offer celecoxib because it does not inhibit platelet function, and monitor carefully. Use with caution if a patient has a history of asthma, and don't use at all if a patient has a history of aspirin allergy. It's just not worth the risk. Now I'm going to skim through one of the world's biggest topics, which is corticosteroids, to say that this is one of the most widely prescribed drugs on the market for many different reasons. And I'm sure you've all used it many times before. There is a distinction with regard to adverse effects between low dose, short term, and high dose, long term corticosteroid use. The low dose short term tends to be obviously far less toxic than the high dose long term. Even with low dose, though, patients can develop weight gain, and also it does lead to osteopenia in some patients. In high doses, metabolic issues, psychosis, osteoporosis, decreased resistance to infection. Fortunately, I'm not going to talk much more about corticosteroids, simply because it would take up the entire rest of the talk, and I wouldn't be able to turn to the real meat of this talk, which is to discuss the longer acting disease modifying drugs. So in 2024, we also categorize disease modifying drugs. We break it down into traditional or synthetic disease modifying drugs, biologic disease modifying drugs, targeted or synthetic disease modifying drugs. And I'll speak very briefly at the end of the talk about biosimilars. So here's another case that might come to your office. A 33-year-old woman presented to her nurse practitioner complaining of nausea. Past history was pertinent for long-standing psoriatic arthritis, which was well controlled with adalimumab and methotrexate. She had no other medical problems. All of her testing had shown no evidence of toxicity. A pregnancy test, which you ordered because that was considered a possibility because of her nausea, turned out to be positive, even though she'd been using an IUD. And it was also true that her last menstrual period was 6 weeks ago, so it was first trimester. Your advice, and you should look at all of these and choose any that apply. Discontinue methotrexate, but continue adalimumab. Discontinue adalimumab, but continue methotrexate. Continue both adalimumab and methotrexate. DC both adalimumab and methotrexate. Consult her rheumatologist. So file the answer as you think it might be, and we'll talk about this at the end of this section. The most familiar drug in the traditional synthetic disease-modifying drug class is methotrexate. This drug was first used to treat cutaneous psoriasis in the 1980s, that is, and it soon became clear that the articular complaints from psoriatic arthritis were responsive also. And then it wasn't long before it was tried in other arenas, including especially rheumatoid arthritis. It remains today the most important and effective of traditional disease-modifying drugs. It's often used in combination with others and it's also used in combination with biologic drugs. It's often as well prescribed with NSAIDs and or corticosteroids. 90% of it is excreted unchanged, and it's highly protein bound. And these two facts have to be considered if a patient, for example, has hypoalbuminemia, and that would effectively increase the concentration of methotrexate. Its mechanism is that it's a dihydrofolate reductase inhibitor. Now, a very, very important fact is that it's given as low dose once weekly, 1 day each week, either orally or subcutaneously, and it's given with folic acid. We'll come back to those items shortly. So it's generally well tolerated, although some patients do develop nausea, stomatitis, and diarrhea. If there are GI side effects, you can give the medication subcutaneously, or you can reduce the dose. It's not infrequent that patients develop abnormal liver functions, and we do check them every 3 months or so. But we do tend to continue the medication if we notice just a minor bump of less than 2 times the upper limits of normal. It clearly can be associated with myelosuppression that's dose dependent, and you have to often, in this situation, rescue with folinic acid intravenously if there's a reason to quickly reverse this. It's true also that adverse events are accentuated by use with other DHTF inhibitors, such as trimethoprim sulfasalazine, and also by pre-renal and renal insufficiency. So there are things you really have to think about when you offer, or you know that one of your patients is on methotrexate. Probably it would be a specialist who recommended methotrexate, but you're seeing the patient regularly, and the patient may not see the specialist and complain of these symptoms of nausea, stomatitis, diarrhea, etc., but may complain to you. So you need to be aware of the meds that your patient is taking, and to work with the consulting physician, who often would be a rheumatologist. With regard to pregnancy, this drug is notoriously associated with congenital birth defects and spontaneous abortions. And you may know that at one point it was used as an abortant in higher doses to lead to medical-induced abortion, although that's not the case anymore. So it's some mothers who've been exposed for a short period of time choose to keep the baby and follow very closely, but many choose to stop the methotrexate and not to keep the child, to have a spontaneous abortion, or to have an abortion, and to start again with a pregnancy while they're not on methotrexate. In point of fact, it's recommended that if you are a patient who is taking methotrexate, you be off of methotrexate for at least 3 months before you begin trying to get pregnant. This is a slide that I won't go over in great detail, but it just shows that you can rescue with folinic acid. And here this patient was given Bactrim, and you can see that the counts went way down. The white blood cell count was rock bottom. And when the folinic acid was started, the dihydrotetrafolic acid was reductase was overcome, and quickly her platelets and her white count rescued. There are other drugs that are in the traditional synthetic DMARD category, which include hydroxychloroquine, sulfasalazine, and leflunomide. Hydroxychloroquine is associated with retinal toxicity, myopathy, including cardiomyopathy, and it's best known for also being a treatment for malaria, but it can be used in combination with methotrexate in early stages of rheumatoid arthritis. The same could be said of sulfasalazine and leflunomide. Leflunomide is a, quote, methotrexate proxy. That is, it's used with other drugs, but uncommonly with methotrexate. It can cause abnormal liver function studies, rash, and diarrhea. And the problem with leflunomide, which I've seen, and it's really tough, is if you have a patient who has severe adverse reactions to this drug, it's not a question of just stopping the drug, because it may take weeks to months for it to just dissipate, because it's fat stored. So you have to, quote, wash it out, close quote, with some cholestyramine infusions. And that is no fun, but it does work if you need to get rid of the drug. So you might see any of these drugs in a patient with rheumatoid arthritis, although less so these days than in the early days of pre-biologic. So what about the practical implications for you with regard to methotrexate? I always take time to emphasize how to write or call in a methotrexate prescription. We do it mostly electronically these days, but you're going to be talking with the patient too, and you need to emphasize to the patient how this drug is going to be prescribed. I always took the time to say, take the methotrexate in one single dose on one single day each week. The problem is if you say take 3 pills per week, which would be a standard starting dose, you might find a patient who takes 1 pill on Monday, 1 pill on Wednesday, and 1 pill on Friday. And that leads to more toxicity than if the drug is taken all at once. So be sure and emphasize, if you have a patient who is on methotrexate, that it should be taken one day, the same day each week. And it would be very helpful for the rheumatologist if you would review that too, because you'd be surprised how many patients who'd come in who are on methotrexate, who are being followed by a rheumatologist and just didn't get it. If you have a patient that has a need for another drug, particularly UTI, say, check the drug interactions and contraindications electronically. It's so easy to do these days, and make sure that methotrexate is not contraindicated. As it turns out, taking methotrexate, as I've alluded to previously, with a drug as common and as simple as Bactrim, is, period, the end, contraindicated, because they share the same mechanism, and Bactrim can lead to profound leukopenia if you don't know about it and you accidentally prescribe it. It's also important that you work with your patient and with the rheumatologist to provide appropriate contraceptive counseling in young women pre-treatment. There's always a question about, well, what about drinking? Can you drink? And I've had plenty of patients who simply say, I'm just not going to take methotrexate because I want to drink. Well, it's true that this subject has been beaten to death in the literature, but it is true that it's okay, most likely, for patients to imbibe infrequently and minimally on special occasions and not have major adverse effects. The number of patients who've developed severe hepatic toxicity from methotrexate is really minimal, and it is worth knowing about. And we do encourage checking liver function studies that regularly, about every 3 months, along with a CBC, and just to make sure that you're not going to see a bump simply because the patient just got their dose. I have them check the liver functions immediately after or just before oral or sub-Q administration, and not at the end of the week when the effect might be maximal. Okay, so case 2. A 29-year-old woman comes to your office complaining of dysuria for several days. No fever or chills. She has a history of rheumatoid arthritis, and her medications include diclofenac, low-dose prednisone, weekly low-dose methotrexate, and oral contraceptives. How would you manage this patient? Choose all answers that apply. Well, we have heard that you should not prescribe Bactrim for this patient. We don't need to stop methotrexate. We don't need to offer avoid Keflex. We don't need to stop prednisone. And we don't need to bother the consultant urgently because we know what to do. So just don't prescribe Bactrim, and be sure and check for other issues if you are thinking of prescribing something else. But the cephalosporins in general are fine. Okay, so what about significant limitations with traditional DMARD therapy for RA? So we've got Bactrim, we've got hydroxychloroquine, sulfasalazine, and the big gun, which is methotrexate. And we had these drugs for years. But unfortunately, after 5 years of treatment with these drugs, only 60% of patients continued to take methotrexate, which was one of the best tolerated, despite the array of side effects I pointed out of the traditional DMARDs. And even more concerning, joint erosions were identified in about 30% of patients after 1 year of therapy with traditional DMARDs, and in 70% of patients after 2 years of therapy. So patients may appear to be doing okay, and sometimes they can continue to come and see you, and right underneath your careful surveillance, they continue to progress. Further, only 2% of patients after 3 years of treatment with traditional DMARDs went into complete remission, and a number that varies depending upon the time of initial diagnosis. As much as 50% of patients are disabled after 5 years of therapy with traditional DMARDs alone. So it was clear from this information that there needed to be a new approach to managing patients with particularly rheumatoid arthritis and other inflammatory arthropathies such as psoriatic arthritis. So the blockbuster of treatments for rheumatoid arthritis and related inflammatory diseases are the category of drugs called biologic disease-modifying anti-rheumatic drugs. These drugs first began to trickle into the market in the late 1990s, particularly spurred on by the observation that infliximab could treat inflammatory bowel disease. And because of the mechanism of action and its profound effect, their profound effect on cytokines, which promote inflammation, they were tried in progressive fashion as new drugs came out in the rheumatic diseases, particularly rheumatoid arthritis. And the response to patients with rheumatoid arthritis has been nothing short of profound. It's a life-changing drug, and I think it's safe to say that I practiced rheumatology for 40-something years because of these drugs. I would never have made it with the limited success that we had with a limited number of tools. So case 3, a 33-year-old woman presents to her nurse practitioner complaining of nausea. I think this is the one that we've already presented. And just look at this and think about what you would do. So the cytokine signaling pathway that's involved in rheumatoid arthritis is depicted here. But the most important thing that you can see is that drugs called interleukins have a profound effect on many different parts of the immune system. And in particular, they can lead to erosion of bone and cartilage. And that is actually one of the major problems and leading to structural damage in rheumatoid arthritis. So it was exciting that we had these drugs to try to apply to patients with active inflammation that didn't respond appropriately to methotrexate. Just a few little characteristics that you might expect from biologic DMARDs. They're produced by recombinant DNA technology. They're absolutely huge molecules, so they can't be taken orally. They have to be offered by either injection or infusion. They generally target cytokines or their receptors, or they're directed against other cell surface molecules. We have a lot of different types of biologic DMARDs used in rheumatic disease, including the class of tumor necrosis factor alpha inhibitors. And these include infliximab, etanercept, adalimumab, golimumab, certolizumab, and I'm sure there are others in the last few years. We also have seen usefulness of interleukin receptor antagonists, including anakinra, and more recently, the IL-6 receptor antagonist, tocilizumab, and sarilumab. And then we've seen other biologic response modifiers, which have been recently developed, such as the T-cell co-stimulation blocker abatacept and the anti-CD20 B-cell depleting monoclonal antibody rituximab, which is used not only in RA, but can be used in lupus as well. Just a schematic to show you. Originally, everything in red in this slide is a mouse-derived part of the antibody. And you can see that infliximab has both mouse and the white part indicates human. Etanercept is an antibody or an anti-cytokine that is only a human, and adalimumab is only a human. And some of the adverse effects of some of these drugs depends upon whether they're simply human or mouse-human. So what's the mechanism of action of the TNF blockade? Well, the variable region of the anti-TNF monoclonal antibody binds to soluble and cell-bound TNF, both the chimeric and the human versions, chimeric being the mouse human. And so the soluble TNF receptor, which would be etanercept, it's linked to the Fc portion of IgG, and it binds soluble and cell-bound TNF. It doesn't fix complement or lyse immune cells, and it can this is in vitro, but in vivo, it can fix complement, leading to cell lysis. So all of these drugs have been tried, as I've said, in a variety of diseases, including in lupus, rheumatoid arthritis, and psoriatic arthritis. And here's a listing that's a little bit more up to date, but I will say that if you watch any big screen stuff these days, you can't help but think that psoriasis is one of the world's most frequently occurring diseases, which is not true. And you can't help but think that there is an unlimited number of options of drugs to treat psoriasis and psoriatic arthritis. And it seems that that is near true. There's been a huge proliferation. And the reason I say that is that even though this list was compiled in 2023, there are undoubtedly 5 more drugs to put on this list right now dealing with psoriatic arthritis. Now, the next few slides I'm going to go through very quickly, and don't think that I'm going to put you to sleep with these response rates and studies and things like this. The point of these slides is not for you to remember all this. It's for you to visually see how these drugs have impacted the treatment of rheumatoid arthritis. So one of the earliest trials was called the Armada trial, and this looked at the effect of adding adalimumab to patients who were treated with only placebo and methotrexate. And you can see, and this is the response rate, the American College of Rheumatology response rate, which is a way to measure effectiveness of treatment. And if you look, every single one of these had a dramatically increased response rate just by adding adalimumab to methotrexate. And this, I think, is one of my favorite slides, effect on radiographic progression at 12 months of anti-TNF and methotrexate. So here we have 3 different kinds of anti-TNFs, etanercept, infliximab, and adalimumab. And in each case, the predicted progression without the anti-TNF was radically changed with adding the monotherapy of etanercept, infliximab, or adalimumab. And I think this is one of the more dramatic slides to indicate the profound influence that these drugs has had on the treatment of patients with rheumatoid arthritis. And likewise, it's very encouraging that many of these patients were able to reduce or discontinue methotrexate that they were taking at the same time. Up to 55% decreased or discontinued, and at least 24% discontinued methotrexate when etanercept was added. Again, another very striking example of how effective these drugs are. We're always worried about having to use concurrent long-term steroids in patients with rheumatic disease. And etanercept in this slide and in this study was profoundly effective at reducing the required prednisone dose. Either 82% of the time decreased or discontinued, and in 69% of patients when etanercept was added, prednisone was able to be discontinued. And that is, in my mind, nothing short of astonishing. I just wanted to throw in this slide on rituximab. If any of you happen to see a patient who has lymphoma and rheumatoid arthritis, you might find that they're on rituximab, because we know that now that rituximab, which is a monoclonal antibody that targets B cells, can be very helpful in treating rheumatoid arthritis. So it also is a treatment for lymphoma. And paradoxically, patients with many of the other anti-TNF medications and other biologics that are used in treating rheumatoid arthritis, some of those may end up with lymphoma. So this is a good ace in the hole. And you might be confused about how this drug could be used, but it could be used in a patient in that scenario because it's effective against both diseases. And this is just an example of the fact that rituximab can actually be given once every 6 months to 12 months in patients with rheumatoid arthritis and on methotrexate. Okay, so what about the adverse effects of biologics? And this is something that I really think people in primary care need to think carefully of these biologics. And I'll give you an example that personally happened to me and one of my patients that involved a family practitioner when I go through this slide. The most concerning adverse effect is that these drugs do increase patients' risk of infection. And that includes reactivation of TB, exacerbation of recurrent chronic or active bacterial infections, prosthetic joint infections, opportunistic infections, reactivation of Hep B. I mean, any infection really could be adversely affected by an anti-TNF. Practically speaking, when we offer these drugs, we check PPDs or quantiferon tests for the presence of evidence that the patient has had TB, and then if it's indicated, the patient actually can be treated for TB before these drugs are offered. And then the most important thing, if a patient develops any signs or symptoms of infection at the first hint, usually the anti-TNF is withheld and the infection is treated. The second thing that is a little bit of a black box is malignancy. There's been almost nothing more profound than a hint that these are associated with lymphoproliferative diseases, but most people believe there's a small but increased incidence. Possibly melanoma skin cancers, in particular metastasis. Again, not highly correlated, but it's always been a suspected issue. Non-melanoma skin cancers can be associated with anti-TNFs, but not solid tumors. So, for example, lung cancer would not be, breast cancer would not be. There has been some data that that anti-TNFs exacerbate stage 3 and up CHF. So those patients would not be a candidate for this type of treatment. It's not likely that these drugs actually cause MS, but it probably is likely that they contribute in some way to the exacerbation or, quote, unmasking of MS. To make matters more confusing for the rheumatologist, they are associated rarely with a drug-induced lupus type picture, particularly since lupus can cause inflammatory arthritis. And in the case of drugs that are injected, particularly rituximab and infliximab, they may be associated with infusion reaction. It's not likely that they interfere with fetal development or cause any pregnancy issues. So they don't have to be discontinued during pregnancy. And then I noted down here what I already have mentioned, that rituximab is used to treat lymphoproliferative disease, and the infection incidence is somewhat increased, but less than expected. Now I'll tell you about my personal experience. I had a patient that I had followed, well, roughly every 4 months or so. And I saw her one day, and she had advanced rheumatoid arthritis for certain. And she was on one of the anti-TNFs. It doesn't really matter which one. And she had developed, in the interval since I'd seen her, some rapidly enlarging lymph nodes that had been biopsied and identified to be lymphoma. And they were enlarging in such a way that it was impairing her airway, and it was deemed really to be an emergency. So she was continued on the anti-TNF, and she was treated emergently with surgical approach. The lymph nodes were removed. And then she came back to see me for a follow-up of her arthritis. Well, it turns out that I contacted her primary physician, and I said, and her oncologist, and I said, etanercept has been associated with lymphoproliferative diseases. Why don't we stop the etanercept and see what happens? Well, this was one of these miraculous situations where within, I'd say 6 or 8 weeks, we had documentation of regression of the size of her lymph nodes. And even though she ultimately died of her cancer, she lived arguably much more comfortably than she would have, and longer than she would have, if we had continued this class of drugs. So in that situation, I don't believe that it actually causes the lymphoproliferative disease, but it certainly can provoke it to get worse more quickly. And in that situation, it was just a question of the doctor's office, the primary care physician's office, just picking up the phone and calling me and saying, gee, we're sharing this patient is on a very complex regimen. I'm not so familiar with the adverse effects of what you provide for her, but did you know that she has X? And that type of cooperation and coordination is what I hope to see a talk like this encourage. There certainly will be people that fall through the cracks, but the more of us who think collectively about the collage of drugs that we share and the collage of patients that we share, the more successful we'll be at avoiding this kind of stuff. So the relative contraindications, lupus, multiple sclerosis, chronic or recurrent active infections, immunosuppression, you can read the list. All of these relate to what I've told you about, but pregnancy is not a contraindication. And so case 3 was an example of teamwork. We stopped the methotrexate, but we continued the adalimumab because she was pregnant. We consulted her rheumatologist, and we were able to, she didn't have to, as I said, stop adalimumab, and she didn't have a flare of her arthritis, which is particularly satisfying and particularly helpful. This, don't even think of anything except that this shows that the immune system is much more complex than we first thought. And this emphasizes the innate immune system, which is something that each of us is born with and doesn't require priming with exposure to antibodies or antigens in our lifetime. And we now know that this plays an important role in a variety of inflammatory situations, including rheumatoid arthritis. And this has led to the development of what are called targeted synthetic DMARDs. And these drugs are are typically very small molecules. They typically are JAK kinase inhibitors, and that is a particular enzyme that's an integral part of the innate immune system. And these drugs, they have been marketed as, quote, the injection, close quote, because they can be taken orally because they're small molecules. And they include, you might have heard of tofacitinib, baricitinib, upadacitinib, and there are a variety of adverse effects that are listed here. And hopefully, you know, again, if you have a patient that you share with a rheumatologist, you can work with him or her to figure out a way that you can help monitor and help these patients in an efficient way use our health system and be available for them to complain to side effects that they may that rheumatologists might want to know.
Dr. Upchurch, I just want to give you the 10-minute warning.
Yeah, I'm on the last 3 slides. Thanks. Okay, so with regard to COVID-19 and biologic therapy, the American College of Rheumatology did come out with some guidelines, and I'm not going to read them for you, but basically anti-malarial therapy can be continued. Any drug that actually suppresses the immune system should be stopped or withheld, and NSAIDs should be discontinued in patients with severe respiratory symptoms. And this is further a statement about reinitiating biologic therapy following COVID-19. I told you I was going to mention biosimilars very, very briefly. A biosimilar basically is a biologic drug that mimics in its action exactly a far less expensive, in a far less expensive way, the mechanism of action of the drug. So, for example, for every drug like etanercept, adalimumab, even infliximab, there have been mirrors or biosimilars that have been initially intended to reduce the price of what is a hugely expensive category. The problem is that even now, up to 10, 15 years after these drugs have been available, and they're continuing to proliferate, we don't tend to use them as often as we should. We feel uncomfortable about them, and yet they do often produce improvement in disease in the same way as the drug that is being mimicked. So let's talk about, on the last slide here, the role of primary caregivers. Well, always remember that you're part of a team, and the rheumatologist is a part of the team too. So it has to come from both parties. The first thing that's most important is that you help us identify patients early with possible RA or other inflammatory rheumatic diseases and refer as soon as possible to a rheumatologist. And I would say, don't just have your assistant call and make an appointment. If you think the patient really has an inflammatory disease, because of the impact of appropriate treatment in the first few months, you take the time out of what is undoubtedly a totally train wreck of a day. Make the call yourself and tell the rheumatologist, make a case for getting that patient in early. Secondly, you're going to continue to follow that patient when she goes to see her rheumatologist and be aware of the drugs that she's taking and in communication with your patient's rheumatologist about possible adverse effects. Obviously, this number 3 is in reference to methotrexate, and we've gone over that quite a bit. But in particular, with regard to DMARDs and particularly biologic DMARDs, be vigilant about symptoms and signs of infection or other possible adverse events, and communicate with the patient's rheumatologist about any suspicions that you might have. Don't wait for it to be so obvious and so late that there's not much that can be done about it. So those are the ways that you can help the most. But I would say of these, probably identifying patients early with possible RA, because these are going to be young women who generally look healthy, and unless somebody suspects that there's a systemic joint disease going on, may be overlooked for weeks to months. And that's what we're really trying hard to avoid. Okay, so these are just some references that you can use to amplify what I've talked about. And I would be happy to take any questions as I've done the 60 mile an hour or faster overview of many different drugs and many different adverse effects. But happy to have the chance to talk to you, and hope it's helpful.
Thank you so much, Dr. Upchurch. This was great. We do have a lot of questions, so we'll get
Good.
into them. Are the topical NSAIDs, Voltaren, any less likely to cause all of these adverse?
That is a wonderful question, and I didn't put anything in about the topicals, but the main reason to the answer is they are less likely to, because the concentration that is the serum concentration is just less. And if you particularly limit the skin surface area to which the drug is being applied, you will further limit the effective concentration. They are not immune to side effects, but less likely than oral.
Great, thank you. Is there any truth to the idea that hydroxychloroquine can assist with zinc getting into the cells?
I don't know. I don't know. I'll try to look it up, and if I find the answer, I'll pass it on to
Yep.
Kristen. It's not a biggie, but in terms of its mechanism of action, but